All right, good afternoon, everyone. We're going to get started. Welcome to our webinar today on HIV testing and linkage to care. My name is Adam Vieira, and I'm here with the National Capacity Building Assistance Resource Center, or the CRC, and I'm very excited to get to our webinar. But before we do that, I just want to go over some housekeeping items. For today's webinar, we'd like for all of you to complete the HPAT survey. You can see that at the top right-hand corner of the screen. You can click on it and then click Browse to, and please complete that while we get started today. If you have questions at any point during the webinar, please you enter those into the questions pod, which is just below the HPAT survey. We will be able to see those questions throughout the presentation, but we'll be taking questions at specific points. So you can enter them at any point in time, and then when we get to a point where we can answer questions, your questions will be listed for us. Finally, you can download the slides for today's presentation on the bottom right-hand corner, and the slides for both presenters are present there. So feel free to go over there at any point, click on one or both of the presentations that are listed there, and then click Download. With that, I am going to turn the mic over to Antonia Rakestraw, who's going to introduce our presenters for today.
Thank you. Good afternoon. My name is Antonia Rakestraw. I'm a member of the Community-Based Organization Initiatives team, and on behalf of the National Center for HIV/AIDS, Viral Hepatitis, STD, and TB Prevention, Division of HIV/AIDS Prevention Program Branch, we welcome you to the second of 3 scheduled Capacity Building Assistance webinars for Funding Opportunity Announcement PS 17-1704, which is the comprehensive, high-impact HIV prevention project for young men of color who have sex with men and young transgender persons of color. Today's webinar presentation will be on HIV testing and linkage to care. The webinar topics were chosen based on common capacity building assistance requests and are part of a comprehensive effort to ensure that interested applicants have an opportunity to hear and view presentations that will assist in developing their applications. During this webinar, we will not be addressing questions specific to the FOA, but will focus solely on today's topic. Please feel free to visit the PS 17-1704 website and the Frequently Asked Questions and General Asked Questions document, as your questions may have already been addressed regarding the FOA in those documents. So let me begin by introducing the presenters for this afternoon. The first presenter is Dr. Benjamin Soy. He's the Deputy Director of HIV Prevention at the New York City Department of Health and Mental Hygiene. Within the HIV Bureau, he oversees the Health Department's HIV testing initiatives and funded HIV prevention programs such as HIV testing, PrEP, PEP, and condom distribution. He's specifically known for his expertise in HIV testing. He has co-authored multiple manuscripts on HIV testing, and he also provides technical assistance to CBOs and other health departments on HIV testing and other HIV prevention topics. Our second presenter will be Jessie Murphy. Jessie is a Clinical Operations Coordinator at UCSF Alliance Health Project. She's a CBA specialist in the USCF collaboration between AHP, the Center for AIDS Prevention Studies, and the Center of Excellence for Transgender Health. Ms. Murphy has offered technical assistance on third-party billing and reimbursement and has expertise with HIV testing in non-clinical settings, outreach and recruitment, linkage to care, testing technology and administration, prevention services integration, and PrEP navigation. So both of our speakers have a wealth of knowledge and experience in the HIV testing arena. So without further ado, I'd like to turn it over to the presenters, and thank you for attending this webinar today.
Good afternoon. This is Ben. I hope that you can hear me. Let me know if any of you are having any problems with audio. So for this afternoon's presentation, I am going to be talking about targeted HIV testing, and then Ms. Murphy will follow up with the linkage to care portion. And for this presentation, I have two learning objectives for you. They are for you to be able to identify the basic components of targeted HIV testing, and also to learn about the strategies for recruitment of your target population for HIV testing. But the topic of HIV testing, targeted HIV testing, is very broad. And some of the things I would not be talking about, however, would be how to select an HIV testing technology for your organization, how to actually conduct or perform the HIV testing process. And I will also not talk about how to conduct quality assurance activities for HIV testing. But before I go on to my presentation, can I have the first poll question? So to get us started, I'm curious to find out which of the following populations you currently serve for targeted testing and linkage to care. Click all that applies. I think most people have voted, so it seems like, oh, I'm going to wait just a little longer. Okay, looks like most everyone has voted. No? So it looks like the majority of you are targeting gay, bisexual, and other men have sex with men of all races and ethnicities. The second one is persons who inject drugs, then black men and women, transgender persons, and Latino men and women. Great. But there are also other groups that people are testing. Okay. So it seems like you're already targeting a lot of different groups, and that's one of the topics that's the topic I'll be talking about this afternoon. So before we talk about this, how does this fit in terms of whole framework of high-impact HIV prevention? High-impact HIV prevention are proven HIV prevention strategies that CDC has recommended, and those activities include HIV testing with linkage to care, which is the topic for today. In addition, it also includes antiretroviral therapy, access to condoms and sterile syringes, prevention programs for persons living with HIV and their partners, prevention programs for persons at risk for HIV infection, including PrEP or pre-exposure prophylaxis, substance use treatment, screening and treatment for other sexually transmitted infections. And certainly, as we're talking about HIV testing and linkage to care, there are these tie-ins in terms of how the testing and linkage to care services can link to these other prevention interventions, because persons who get tested, if they're found to be positive, may then need to be linked to care and start on antiretroviral therapy, or if a person is negative, they may be referred for prevention services programs such as PrEP, or if needed, screening for STIs or substance use treatment, or any of these other interventions. And certainly, testing is very intimately linked with the HIV care continuum. And this is a framework for us to really think about how to approach providing services to persons living with HIV and also for persons who are at risk for HIV. And then I think the key point in terms of one of the key points in terms of this is that persons first need to be diagnosed first, and then once they're diagnosed, they need to be linked to care, stay in care, engage in care, and then start on treatment, and then finally, once they're started on medications for HIV, they were virally suppressed. But as we can see with this, there is a drop-off from each of these steps in terms of the people who are living with HIV. Only a certain amount know that of their status, and then they're linked. But the first important step of this, of course, is HIV testing so that people who are living with HIV are first diagnosed. So when I think about HIV testing, there's really two broad approaches that I would think of. For clinical settings, it's really looking at routine screening or routine testing, which is offering testing to everybody who shows up. And then when we have in non-clinical settings, then we're talking about targeted testing. And very recently, CDC has provided new guidance on HIV testing in non-clinical settings. So if you have not looked at this, I would definitely encourage you to take a look at this document beforehand, because it would be helpful in understanding about implementing a HIV testing program in non-clinical settings, but also would help with your grant application. So what's the importance of targeted testing? And for me, really, targeted testing really allows us to reach persons who are at risk for HIV who may not access healthcare services. Because if we focus only solely on providing care in clinical settings, we know that there's some people who never access healthcare services or rarely access healthcare services. So we want to make sure that for those people who don't access healthcare services, they still have an opportunity for testing. But also we know that sometimes persons at risk for HIV, even though they may access healthcare services, but even if they access services and are offered HIV testing, they may refuse HIV testing because of stigma or for other reasons. So for persons at risk for HIV infection, then we want to offer them another opportunity to get tested, and preferably in a way that is confirming to them and also allows them to do it without stigma. So in terms of our topic of targeting, what is targeting? When I think about targeting, I would define it as the process for defining how you would direct your HIV services to select groups of persons. And I think for our programs, two of those key points in terms of the groups of persons that we want to provide services to would be persons who are unaware of their HIV status and also persons who are at risk for HIV infection. Next then, when we look at the topic of target HIV testing, we want to think about what is our intended outcome, because I think that for target HIV testing, there could be a lot of different outcomes that we want to have as a result of the targeting. Certainly, one of the most important ones is we want to assist people in learning about their HIV status. But in addition, as I mentioned, if someone is tested for HIV and found to be living with HIV, we will also want to link people who are newly diagnosed to HIV medical care. And sometimes we also know that as we're offering testing to people, we may sometimes come across persons who've been previously diagnosed with HIV. And if that's the case, if they're not currently in care, we want to re-engage these people to HIV medical care. And I think what is new in our conversation in terms of one of the outcomes for target HIV testing is that with the advent of pre-exposure prophylaxis or PrEP, we also now want to think about linking persons who have a negative HIV test result to these prevention services. So while finding someone who is newly diagnosed with HIV and linking with care is very important, we may have all these other outcomes that we want. And depending on what are these associated outcomes you may want, it may possibly change the approach that you would take in terms of your targeting. So once we've kind of decided what our intended outcomes are for target HIV testing, then what are the components? What are the different steps that we need to take? First, you need to figure out who are you going to target for testing. Once you've decided on the population that you're going to target, then you want to figure out what recruitment strategies you'll be using, where you would recruit the persons, at what time, how you're going to do it, and also once you've done all that, you want to know if your efforts are effective. So the big question is, who would you target? And already in the beginning, seems like many of you are targeting different groups. But specifically for this, in our conversation, if you're considering, if you don't know who you would want to target, one of the first steps I think that makes the most sense is look at what are the national recommendations. What are our funders telling us would be groups that would be high priority for targeted HIV testing. So two of the ones I think are really pertinent are the National HIV/AIDS Strategy and also CDC's high impact HIV prevention. And when we look at the recommendations for these two different programs, we find that the National HIV/AIDS Strategy, actually the list I showed you earlier comes from that, are gay, bisexual men and other men who have sex with men of all races and ethnicities, Black women and men, Latino women, men and women, persons who inject drugs, youth aged 13 to 24, people in the southern U.S., and transgender women. And when we look at the what's listed as priority populations in high-impact HIV prevention, they're very similar. Gay and bisexual men of all races and ethnicities, African Americans, Latinos and Hispanics, persons who inject drugs, and transgender individuals. So there are a lot of similarities, but there are a few groups in the national HIV/AIDS strategy that are not mentioned specifically in the high-impact HIV prevention. But certainly, we do know that there are differences in terms of epidemics for HIV. So in addition to looking at the national strategy, we also want to consult multiple sources to see about what does the epidemiology shows us, both nationally but also locally. So in terms of national epidemiologic data, there are some resources available that can help you in this aspect. Certainly, I think it would be silly for me not to mention that CDC provides a lot of information about HIV for the U.S. So certainly I would go to their Statistics Center to find out about statistics for HIV nationwide, which also provides more regional pieces of information. In addition to the HIV/AIDS Statistics Center, AIDSview, which is a collaboration between health departments, also Emory University, also provides a more graphical depiction of statistics for HIV that you can look into, and it also provides local statistics that may be useful. And then, of course, then, in addition to AIDSview, there may be other sources for local epidemiologic data that you may want to take advantage of also to help you determine which groups to target. And just for an example, for New York City, we release our epidemiology and surveillance data every year. So this is a resource that agencies can use to find out what is epidemiology for New York City. And likewise, I'm sure in your jurisdiction, you have similar resources that may be available to you that you can also access. But beyond looking at epidemiology, I think it also makes sense for us to also then talk to community members and also other health providers to find out what are the needs of the community to make sure that that we address those needs, sometimes maybe even before the data shows up. But even when you have all this information, it may be a lot, there's still other things you may want to consider to help you refine the target. Because even in the different groups that the National HIV/AIDS Strategy and also high-impact HIV prevention, they list a lot of different groups. And you may want to look at race and ethnicity as one factor to consider in terms of how you want to refine your target. You also want to look at risk factors such as sexual partners. Do they have some, multiple? Also, who are their sexual partners? Are they men? Are they women? Are they transgender persons? Do they engage in drug use? What's their housing status? What is their gender? Are they male, female, transgender? Also, you want to look at age. And then beyond all those specific sort of demographic risk information, you also want to look at, are there any disparities in terms of HIV epidemiology for your area? Are there disparities in terms of HIV diagnosis? So they could be certain groups may have higher diagnoses for HIV, or it could be certain regions or certain populations with higher rates of HIV diagnoses. Or you may look at concurrent HIV diagnoses, which is persons who have both HIV and an AIDS diagnosis. Other disparities you may want to look at is HIV-related mortality and also viral load suppression, or more specifically, the lack of viral load suppression. So are there certain groups in your jurisdiction where once they start on medication, the percentage of people who are virally suppressed are not as high as other groups? That may be a group that you want to target services to. In addition, you want to think about trends and statistics over time. And then more specifically then, when you think about how it applies to your agency, you want to think about what's your staff experience working with those populations. And certainly, even if it's a high-risk population, you want to consider whether it fits in with your agency's mission. So if your agency mission is really is to provide sort of harm reduction services to persons who inject drugs, you may or may not be able and have the staff who are experienced, but also fits in with the culture of your agency to, let's say, serve persons who are from the LGBT community or transgender. So you may want to just look at sort of like your staff experience, also the fit of the population with your agency to make sure that if you do target a different group, that actually makes sense. So that's a lot of information. So I thought to help us kind of drive the point a little clearly, I thought I'll give you a targeting example. And one I'm going to use is a fictional community-based organization in New York City. So this is not an agency that I'm thinking about, but this fictional agency provides prevention services, including testing to Black African-American men and women. And for this agency, their testing program predominantly tests Black heterosexual men and women. And what they found is that they've only identified a few people. They've identified a few people with previously undiagnosed HIV infection, but the program has not identified as many people with new HIV infections as expected. So they've been testing. They found a few positives, but not as high as expected, and they want to improve their performance. So they're thinking about who should we target, and maybe can we refine the people that we're targeting testing to. So as we talked about before is when you think about targeting then, one of the first things you want to think about is what's the intended outcome of targeting. And so from this agency, what they're talking about is they're testing people and they haven't found positive. So identifying persons with new HIV diagnosis is one of the main primary outcomes of what they're looking for. Once they've decided on this, then what are the groups of people recommend? The next thing we want to look at sort of like who are the groups that are recommended for target testing, and see if who they're targeting aligns with those recommendations or not. So when we look at the National HIV/AIDS Strategy and also the high-impact HIV prevention, we find that the groups that they're targeting, Black men and women, totally fits in. So at least on the broad scope of things, it seems like what they're doing is totally appropriate. So we may have to dig a little deeper to figure out that if they're not having the high testing positivity rate, what else they can do to better refine their targeting. So the next step would really be for them to look at local epidemiologic data and see what does it show to see if it can help. So I'm going to use, since it's my fictional agency is from New York City, I'm going to use New York City surveillance data to look at this. And from our report, we'll first look at what does the picture show for New York City in general. And when we look at this, I'm just going to have us focus. We see that there were, in the year 2014, which is the most recent year for our report, there are 2718 new diagnoses in all New York City. But when we look at Black African-American persons with new diagnoses, there were 1193, which accounts for 43.9%. So it makes sense then in looking at the data, certainly targeting black men and women may make sense because they account for almost half of the new diagnoses in New York City. So our local epidemiology data does confirm the national recommendation, but that doesn't help the agency because they're still having problems in finding positives. So what else can they look at? So we can then look more specifically at black men and women to see if that could give us more information. So looking at that tab then, what we find is that in New York City, black men account for 71% of new diagnoses amongst black men and women. So I think even from this one step, the agency, if they're testing both black heterosexual men and women, they may see how many men versus how many women they're testing, and also then look at sort of like what's their expectation. If they're testing equal numbers of men and women, but our epidemiology shows that the majority of the diagnoses amongst men, they should not be expecting as many positives when they test women as men. So they just need to set realistic expectations in terms of the performance of the agency, even based on this local statistics. In addition to that, when we look at sort of transmission risk, we find that of men in general, the major transmission risk is men who have sex with men, and they account for 63.4% of all the new diagnoses amongst men. And when we compare that to heterosexuals only account for 7.9%. So I think this is already very telling. So if the agency is offering testing mainly to heterosexual black men and women, even of the men that they test, their likelihood of expecting the men to have positive results, if the information about whether they're heterosexual or have sex with men is correct, we would not expect a lot of heterosexual men to have positive HIV diagnoses. So it could partly then explain why they are not finding as many positives testing heterosexual men and women. And then another thing that we can also look at, in addition to sort of race, ethnicity, and transmission risk, is also age group. So in looking at sort of different ages, we see that of black men, 40.6% of new diagnoses amongst those aged 20 to 29. So in think about this then, moving forward, they may want to, if they're targeting certain ages, they may want to target the age group where there are higher percentages of positives, such as those who are 20 and 29. So from our example, then after reviewing the data, the testing program should not be, as I mentioned, be surprised by the low testing positivity amongst heterosexual men, but also women. And if the program wants to improve their testing positivity rate, they may want to consider targeting, if they may want to do a little bit more refining. If they still want to target heterosexual black men, maybe they should consider focusing on more younger black men, especially those aged 20, 29, to see if they can find more of the people who are at the more epidemiologic risk group for HIV. But in addition, if the program could consider shifting their target, they may also consider shifting or adding black men who have sex with men to the group that they offer testing to, as another way to increase the positivity rate in their testing program. However, since this program predominantly provides services for straight black men and women, they need to consider whether the shift in the population really works with the agency. Is the program able to work with black MSM? Do we have an environment that is welcoming to black MSM? So these are things to consider as we're kind of going, as you're considering who you target, but also if you're thinking about shifting the groups that you target, you want to take that into consideration. Now, once you have selected a group that you want to target, the next thing you want to do is you want to be familiar with your target population, and you also want to design a strategy that considers where's the best place to locate the target population that you want to serve, what is the best time to reach them, what messages should be delivered, how these messages should be delivered, and then who should be delivering these messages. Because we know that sort of like even if you've figured out I'm going to target young black MSM in New York City, not all places are equal. Some places may be better, but even if you have the best place, certain times may be better places, better times to reach them, and you definitely want to have a message that's appropriate. It may be that the parks and strolls may be a place that you can find some of these men, but if they are in the strolls looking for sexual partners, going to them to talk about HIV testing may or may not be the appropriate time. So how are you going to deliver your messages so that if they're looking for a sexual partner, they would be interested in talking to you? And you may want to consider then, instead of offering testing right then and there in the stroll, it could be that you would let them know about testing opportunity so that they can, when they're not looking for a sexual partner, that they can then take the time to come to your agency for testing. So in terms of once you figured out who you're going to target, you need to think about your recruitment strategies. And I'm going to touch on the different recruitment strategies that you can use, but those are street-based and venue-based outreach, internal referrals, external referrals, internet outreach, social marketing, social networking, couples HIV testing counseling, and then testing of partners who are HIV positive. So before I dive into some of these strategies, can I have the second poll question? I'm just curious to know, what are the recruitment strategies you're currently using for target testing? Click all those that apply. Great. I think everyone has more or less finished. So it looks like the majority of you use street-based and venue-based outreach, but also you use, let's see now, I think social networking and social marketing, in addition to sort of referrals, internal and external referrals, internet outreach, social marketing. So it seems like you're using a lot of different ones. There were two others. I'm curious, for those who type in other or who click others, can you type in what other strategies you're using, if you want to?
You'll have to type them in where it says submit your questions, and we can read them from there.
So in looking at your responses, it's good to see that you are using a variety of different strategies. I think that's really, it's great that you're doing that, because if you rely on only one strategy, putting all your eggs in one basket, it may, if things change, it may not work very well. So it's always good to use more than one, but certainly even though I list a whole bunch of different strategies, does not mean that you need to use every single one. But I think it's a good idea for you to be aware of the different strategies. And when things change and you're finding that your program is not performing as well, in terms of either you're not finding as many positives, or if you're thinking about using your program to also refer persons for PrEP, you may, and you're not finding a lot of people who are eligible for PrEP, that you may want to then consider having other strategies that you have not been using before as another way to supplement what your program is doing. Can I go back? Great. So in terms of the recruitment strategies then, seems like you're using all of them. I'm just going to touch base on sort of like what I think those are. There's street-based and venue-based outreach, which is really providing HIV testing in locations where you think your focus population may either live, socialize, or receive services or find partners. And that could be gay bars and clubs. It could be parks and strolls. It could be places where people are getting services that you may want to provide, where you can provide outreach. But as I mentioned earlier, when you're using sort of street-based or venue-based outreach, you also want to consider what day of the week that you want to provide, you want to do outreach and what time of day, because probably in these locations, date and time does impact how many persons you may find in those locations and maybe how receptive they are to your to outreach. In addition to sort of doing outreach, many of you provides more than just HIV testing services. So you may have clients who are already receiving other services from your agency. So internal referrals could be another way for you to figure out persons that you can provide services to. In addition, I'm sure that you have many partners in the community that you also work with, collaborate with to provide services. So it could be that if they're not doing HIV testing, they could be also a source for external referrals for them to refer clients to you for services. That's another way to target folks. What is much more used now is definitely internet outreach. And when I use the word internet, I'm using more than just the World Wide Web, but I'm also talking about sort of geo, also all the different online services. So it could be chat rooms, and that's definitely, I think, when you think about outreach, it could be using social network sites such as Facebook, or and then there are definitely hookup sites, Adam for Adam, Manhunt, Bareback RT, and then most popular now are the mobile applications that we use on our phones. So Grindr, Jack, Scruff, Tinder, and then there are other ones such as Craigslist, which has a section on for persons who are looking for sexual partners, but that could also be another place for you to do outreach. I think one of the things that you need to be aware of, though, when you're doing this is some of these may have certain rules. You may have to engage with the providers first to do this. So, for instance, Craigslist, there is a section where people may be looking for sexual partners, but if you're going there to provide prevention services, you may be kicked out because you're not actually using those services for what is intended, and the people may prevent you from kind of continuing using those. So it's good to know what the rules are for these different online venues, and then also it may be useful for you to also contact folks. And I just saw someone says that Blockade chat does not exist anymore. Thank you so much. But bgclive.com is still active. Thank you. In addition to internet outreach, there's also social marketing, and that could be use of media such as palm cards, flyers, brochures, posters, advertisements in different forms to reach your target population. It's often useful to use social marketing in addition to your street outreach or your venue-based outreach to reach different populations. Separate from sort of like from internet outreach and social marketing and social network strategy. As you know, all of us have friends and people that we hang out with. And the people that we hang out with likely share something with us. And through these networks, it could be one way for us to leverage these relationships between people within a social network to really encourage at-risk persons for HIV testing. So there is a testing strategy for social networking that could be used to help you identify at-risk networks and also then to test those people within the networks. And then more new to the conversation is here, at least domestically in the U.S., this is the use of couples HIV testing and counseling. The approach of this is different in the sense that you have two or more people who are in a sexual relationship who come together to be tested, but what is at least different for us in New York is instead of oftentimes when a person in a couple comes for testing, they go to a testing program and then they're shunted off to two different people who test them separately, they learn about the results separately, and then it's incumbent on the persons being tested to share their results. But with couples HIV testing and counseling, the approach is two people are in a relationship, they go in for testing, they get tested together, and the counselor will give the results to both of them together at the same time. But also with this intervention, the testing program staff also facilitates a discussion between the couple on disclosure and sexual agreements. So this is a unique way for us to, in addition to providing testing, also to provide some prevention services with folks. This is another way that could be used to encourage testing. And then finally, there's the testing of partners who are newly diagnosed with HIV. So that may be a function more of your health department in terms of offering this, but certainly if you have someone who's newly diagnosed with HIV, finding out who their partners are, getting them, doing partner notification, and then offering services to them could be another way for you to identify people who may be potentially at risk for HIV. And then once you figure this out, we're kind of coming to the end, is you really want to think about how you're going to implement your recruitment strategy. You need to hire and train your staff in your strategies, especially if you're thinking about using social network strategy or couples testing. There are specific trainings available through CDC and that you can request. So if you're interested in any of those, you can submit a CRIS request for training in those two topics. Certainly, depending on the group that you're targeting, you may have to train your staff on linguistic and cultural competency to make sure that they can appropriately message and talk to the populations that you're targeting. And then certainly, you need to build those relationships and get the buy-in. If you are going to a venue, you want to talk to the venue owner, talk to the staff, let them know what you're doing, and definitely get the buy-in. One of the things is sort of like if you're interested in testing, let's say, in a bathhouse or a sex club or sex party, you definitely want to make sure that you communicate with the owner to get them to allow you to do it, but then also maybe help them be a collaborator so they can help you actually promote your testing services at their event. And then if you're going to new locations, you also want to get buy-in from the community so that they know who you are, that you're a trusted resource, and that they're open to your providing services in their neighborhood. You also want to build your internet and social media skills, and then lastly, you want to consider the use of incentives. And I think the use of incentives is a two-edged sword. Certainly for certain groups or certain persons, incentives may incentivize them or get them to test in a sense that they may not do so otherwise. We also, at least for us in New York City, we found that there's a lot of people who've tested, and some agencies provide a lot of incentives. And what we've done is now create a culture where people expect to get an incentive in order to test. And so as a result, people may not test if you don't have good incentives, or you have people who are previously diagnosed with HIV who are testing for the incentive. So that may cause you to find positive but not newly diagnosed positives. And then lastly, when you have all those in place, I think even if you have found the perfect population and have found the perfect recruitment strategy, one thing that we do know is that things change, so that certain neighborhoods or certain venues or certain populations that may be at risk may not be as risky moving forward. And especially now as we're introducing more and more prevention services, including PrEP, we may have to reconsider the different groups that we're targeting. So in order for you to figure out how well your program is doing or not, you really need to be able to evaluate your program. And so when you're thinking about implementing target testing, you want to know what are those key program indicators that you want to use. What are the numbers of people that you've encountered? What's a number that's referred either internally or externally, or even from if you're doing street outreach, how many referrals have you done, and then how many people have you tested? And of those tested, how many of them have a reactive test result, how many are linked to care, and then how many of them are linked to prevention services. So in addition to those program indicators, you also want to establish targets for them. So if you're thinking about number of persons encountered, you may want to say, well, when we do street outreach, how many do we expect per night? And then you can monitor to see that. And you want to then monitor how well you're doing against those targets. You want to set a frequency to figure out how often you're going to look at that. It may be that if you're going to a new place, you may want to look more frequently, maybe every week or every 2 weeks, and then periodically you may want to look at this. And then as you're moving forward, you may want to look at how many people you test and how many positives you have, and see, are you hitting those targets or not? And if you're not, you may then want to do what my example did, is relook at the populations that you're targeting. So that's my presentation on targeted HIV testing. Ms. Murphy's going to talk next about linkage to care, and then we'll take questions at the end.
Great, thank you, Ben. So as mentioned, my name is Jessie Murphy, and I work at the Alliance Health Project, along with the Center for AIDS Prevention Studies and the Center of Excellence for Transgender Health, is part of the Capacity Building Assistance Partnership at the University of California, San Francisco. I'm going to speak today about another critical task of any HIV testing program, and that is linkage to care. By the end of this presentation, you'll have a better understanding of what is meant by linkage to care, as well as elements and strategies to help with planning and implementing a successful linkage program. Linkage to care refers to the process of connecting people with HIV to HIV medical care. Once in care, clients can be further evaluated, offered treatment, and monitored over time. Linkage may also involve referral to other services such as healthcare system navigation, behavioral health and other support services, and partner notification. So why is linkage to care important to HIV prevention? Well, there are benefits to starting HIV treatment at any stage of the disease, but the likelihood of success is significantly increased when treatment is initiated as early as possible in the course of infection. HIV treatment suppresses the virus, reducing the symptoms of infection and the negative impact on health. And treatment also significantly reduces the chances of passing the virus to sexual or injection partners, resulting in fewer new infections. Fewer infections and people with HIV living longer, healthier lives reduces the burden of illness and loss on the community and lowers healthcare costs for society as a whole. So if you weren't already, you're now familiar with the HIV care continuum from Ben's presentation, and it shows us that the largest discrepancy along this continuum is between the percentage of people diagnosed with HIV and the percentage engaged in care. So increasing the number of people who are in HIV medical care can in turn significantly increase the number of people receiving treatment and achieving viral suppression. So here's another way to look at it. According to this slide from the CDC, of the people living with HIV who are not virally suppressed, 2/3 have been diagnosed with HIV but are not in care. So that difference means an enormous lost opportunity to benefit these individuals, their partners, and society. So why is it that despite the benefits of HIV treatment, there are so many people living with HIV who are not engaged in care? The short answer is that there are many barriers that prevent access to care or make it more difficult for some individuals or groups. These barriers can be personal, cultural, institutional, and structural. And they can also overlap and interact in combinations, which makes them that much more difficult to overcome. So I've listed some barriers here, and I'm sure that you all can come up with additional examples from the clients with whom you work. There's financial barriers, such as paying for medical visits, laboratory tests, and prescriptions, as well as the cost of travel, childcare, missed work. Problems accessing care, especially in rural and resource-poor settings where there are not a lot of providers or where there's a lack of culturally competent or appropriate services. Stigma and discrimination associated with having HIV or HIV-related behaviors or just being a member of certain groups. In fact, stigma likely accounts for many of the HIV care continuum disparities observed among people of color, men who have sex with men, and transgender people. Fear of medication side effects or concerns about interactions with other medications or drugs. And of course, all kinds of competing life needs that we all face and which may be heightened by issues such as mental health concerns, substance use, trauma recovery, housing problems, food insecurity, or other concerns that either directly interfere with connecting to HIV care or simply take priority over it. Let's see, before we move on, I'm curious to know, let me go back, if this is familiar to you all and which of these barriers or others are experienced by the people that you serve. So I guess, Cindy, could I have the third poll question, please? I want to take a moment to vote, and if there are others that aren't listed, if folks wouldn't mind typing that into the question box. And Cindy, I'm not seeing anything in the question box.
I'm keeping an eye on it. I don't.
Okay.
Yet.
Okay, great. I didn't see anything during Ben's presentation either, so I just want to make sure it's
I'll let you know.
Not me. Okay, it looks like folks have wrapped up, and not surprised to see stigma and discrimination topping our list, and looks like mental health and substance use coming in close second. Okay, great, thank you. Okay. So how do we go about designing and implementing a successful linkage to care program, and in particular one that is going to address and reduce these barriers? Well, one thing that we know is that direct linkage to HIV care at the time of diagnosis is critical to promoting timely access and treatment initiation. And it's important for HIV testing programs to provide this service, especially when conducting testing in non-clinical settings. Ironically, being housed in a non-clinical environment is precisely why this linkage can be difficult, since additional steps must be taken to connect those who test HIV positive to HIV clinical care. So this might be a good time to clarify some of the terminology that is used when discussing linkage to care. In particular, three terms: referral, linkage, and navigation. Referral is the process by which a provider offers a client information about services that respond to their particular priorities and needs. It may also include helping the client identify any barriers to accessing the services and together developing a plan to address those obstacles. Linkage is the outcome, the confirmation that the client actually accessed the services. Linkage usually includes a goal that a client be connected to services within a certain time frame and that this result is documented. And navigation is the system that supports the clients in engaging services over time. Here, the purpose is not only to offer direct assistance in accessing services, but also to increase the client's ability to do so on their own. So I'm going to describe some best practices for successful linkage to care, and these are the steps that would take the client from beginning to end in the linkage process. We'll go over how to assess and prioritize referral needs, how to plan the referral, how to facilitate access to services, and finally, how to confirm and document linkage. And while this process can be applied when linking clients to any service, including services for HIV-negative people, for example, PrEP, our discussion today will focus primarily on linkage to medical care for HIV-positive people. So step one is to figure out what the client's most pressing needs are related to their HIV diagnosis, their readiness to engage in care, and the concerns or challenges they anticipate accessing services. Here you're checking in and using skills like active listening and open-ended questions to solicit this information and establish rapport with your client. A few things to keep in mind. First, if someone has just received a preliminary positive test result or a confirmed HIV diagnosis, they may not be able or willing to process a lot of information or future planning. If that's the case, sometimes the best course of action is to make a simple plan to provide the client with some interim resources, assist them with getting whatever support they need in that moment, and follow up with them in the next few days. Second, don't pretend that as linkage providers we don't have an agenda when it comes to prioritizing referral needs. Our goal is to connect people to an HIV medical provider. However, that connection is less likely to succeed if your client has other concerns that take precedent and you don't try to first address those. And finally, it may not be possible or appropriate to address all of the client's needs. So prioritize those that the client decides are most important to their health and well-being. And then be prepared to refer them to additional services that can take over where your limited role leaves off. Okay, so let's imagine a client. We'll call him Andre. Andre is 20 years old and identifies as a bisexual man. He recently moved to your city from a small suburban town about 50 miles away. He received a preliminary positive HIV test result on your mobile testing van outside a nightclub. At the time, he didn't want to talk long, so you gave him your business card, the HIV Nightline number, and a list of local resources for people living with HIV. You helped him make a plan for how he would get home that night and to identify a support person, his cousin Jordan, with whom he lives. Then you agreed to call him on his cell phone after Jordan goes to work on Monday. So on Monday, you ask Andre how he's doing. He says he's feeling depressed and that he spent most of the weekend in bed. He hasn't talked to Jordan because he's worried about his cousin's reaction. He explains that Jordan has been on his case because Andre hasn't contributed to the rent since arriving 5 months ago, and he's worried that if his cousin finds out that he has HIV, he may kick him out. Andre explains that it took him a while to find work, but that he recently got a job as a stockroom worker. He knows he has health insurance through his employer, but he doesn't have a primary care provider, and he isn't sure how to take advantage of his benefits. So what are Andre's referral needs, and how do we go about prioritizing them? Well, first, Andre needs help using his newfound health benefits, particularly around finding a doctor. He also mentioned feeling depressed and is having second thoughts about relying on his cousin for support. And he's worried about his current living situation. So step 2 is to plan the referral. This means both customizing the referral to best suit the needs of the client and helping the client to strategize the steps that he will take to access the services. For example, Andre has health insurance, but he's not sure how to take advantage of his benefits. As you inquire further, Andre remembers getting some paperwork from his employer and agrees to look for it. You suggest that Andre could also contact his Human Resources Department for more information. You explain that once his health benefits have been figured out, the next step will be for him to see a doctor and probably have some laboratory tests done. When you mention this, Andre says he doesn't think he can make that work with his new job. The shifts are long and he hasn't yet accrued any personal time off. So acknowledging Andre's concern, you add that you'll try to help him find a provider with appointment times that fit his schedule or that's located close to his workplace. The following week, Andre meets you at your office one evening after work. He brings the welcome packet that he received from his job, and that includes information about his health benefits. Together, you go online to the healthcare provider website to register his account and select a doctor. You find a doctor on the same bus route as his work and are able to make him an initial appointment for a late afternoon so that he can go after he gets off work. And you provide him with some vouchers to use for the bus. You also provide him with information about a drop-in group for LGBTQ youth that meets on Thursday evenings. Step 3 is helping the client with whatever they need to connect to medical care. This can mean assisting with insurance enrollment or a medical assistance program, or finding support services to address other needs. Many times this involves very basic practical help around appointment logistics. It might also involve providing moral support to help clients follow through on the referral. So on the day of his appointment, you text a reminder to Andre and ask him to call you after his appointment and let him know how it went. You don't hear back from him, so you call him on his cell the next day and learn that he couldn't make it to his appointment because his work schedule changed at the last minute. He hasn't rescheduled the appointment yet, so you offer to help him do so and to accompany him to the visit, and he accepts. Step 4 is confirming that the client has successfully accessed the service to which you referred them. So here you want to be clear with your clients that you will be in contact and that you would like them to let you know when they access the services. Set an expectation about how and when you will contact them. You can also collect multiple forms of information and then ask them which they prefer. Also ask about the need for confidentiality when leaving messages. If necessary, you can agree to how you should identify yourself and your reason for calling. So for example, since Andre didn't want to disclose to Jordan, you agree to only contact him on his cell phone. If someone has limited access to phone or email, you might see if someone else can relay a message, or else set up a time to meet in person at a later date. Consider asking the client to sign a release of information so that you can follow up with the provider directly to confirm that the client accessed the services. And finally, you'll need to document the outcome. So check with your funder or local regulatory agency about what documentation they want to confirm successful linkage. You may wish to record the following: basic information about the referral, any assistance or incentives you provided to the client, the date that the linkage was successfully achieved or the reasons that linkage was not successful. You might also want to note the client's level of satisfaction and any client feedback, plus any challenges the client experienced when attempting to access services. So the doctor is able to see Andre the following week. You meet Andre at his work and accompany him on the bus to his appointment. You sit in the waiting room until he finishes his appointment. He tells you he needs to get some lab work done, and then he'll be referred to an HIV care doctor within the same medical practice. You ask Andre if you may contact his doctor to confirm this. He agrees and signs a release of information form. 10 days later, you contact the doctor's office and learn that Andre has not attended his initial visit with his HIV care doctor. You text Andre and ask if you can set up a time to talk on the phone. During the call, Andre reports that he hasn't had time to call them back and is feeling overwhelmed. He hasn't been sleeping well and has been late to work a couple of times, and he's worried about losing his job. You ask if he'd be interested in longer-term support from a case manager to help him handle his medical care and other needs. Andre is hesitant at first and asks why he can't keep working with you. You explain that your role is limited, but that you work with some awesome people who could help him further, and he agrees. You arrange for the three of you to meet and make a warm handoff to a case manager, Sue, at your agency. A week later, you check in with Andre to see how things are going. He likes Sue, and he now has an appointment with his HIV care doctor for the following week. You complete the necessary forms, record the dates and types of interactions that you've had with Andre and his other providers, and after another month and another missed appointment, you get written confirmation from his doctor's office that Andre has completed an initial assessment with his HIV medical provider. So Andre's story illustrates the steps that you might take to help link a client to HIV medical care, including both the challenges and some strategies for handling those challenges. Now I want to talk a little bit about the infrastructure and resources within your organization that can support these services. In some ways, the steps for building your agency's capacity parallel the steps of the linkage process. You begin with assessment and prioritization of needs, this time the needs of your client population as a whole, and then work with other providers in partnership to ensure that your clients can successfully access their services. Step 1 is to identify the populations that are impacted by HIV in your area and are or could be served by your agency. Step 2 is to solicit input from people who know something about these populations. So this should obviously include representation from the affected communities themselves, including current clients, as well as your own agency staff, other community service providers, local health department, any funders or other agencies that may have specific requirements regarding linkage. To achieve this assessment, you can use written surveys, facilitated focus groups, or interviews with key stakeholders. You might also want to research local epidemiology, funding requirements, or other reporting obligations. Basically, your goal is to collect information about the preferences and difficulties experienced by the population you seek to serve as they try to access HIV medical care, and to identify your responsibilities around documenting their process. So then, based on the information you've gathered, step 3 is to determine 3 things: which services your agency can deliver and which must be referred out, what human resources or staff training you require to provide these services, and how you'll connect clients to services that you do not currently provide. If you have a small number of staff who perform all aspects of HIV counseling and testing, then it might make sense for all of them to get trained to refer their clients to HIV medical care and to follow up with them accordingly. On the other hand, if you employ a lot of volunteers or you have a high rate of turnover, it might be better to train a select number of linkage staff to become resident experts. No matter what, you'll need to develop a system to help linkage staff stay informed on advances in HIV treatment and local resources. You can make use of online resources, conferences, or, and here's our plug, capacity building assistance from the CDC and its partners. You'll also need a plan for evaluating staff performance and client satisfaction in order to monitor your program's success and assure or improve quality by making necessary adjustments. Step 4 is to research local medical care providers to whom you could link clients. These might include public health clinic staff, private doctors, and other healthcare providers serving people living with HIV. You may also want to research the availability of providers of other services, such as medical case management, transportation or transportation subsidies, psychosocial support, mental health and substance use treatment, housing assistance, and benefits counseling. Once you've compiled your list of providers, step 5 is to reach out to them. If you're establishing a new relationship, you might begin by sending them a letter explaining your program and client population, your desire to refer your client to their services, and the volume of referrals you expect to provide. From there, you can follow up with a meeting to create more specific protocols and identify point people in both agencies. Ideally, you'll find providers who have experience working with your priority populations and who can meet the particular needs of that community. For example, if you're working with people who inject drugs, your ideal would be to find an HIV care and other service providers who approach drug use from a harm reduction perspective and who can offer related resources such as overdose prevention or syringe access. At the very least, you want to find providers who will be respectful and compassionate toward your clients. Of course, you may be doing this work in an area that doesn't have a lot of resources. In this case, you might find if providers are open to expanding their expertise. If so, you could share information with them about your client population and suggest resources that can help them learn more or receive training about best practices to respond to your clients' concerns. The more that you can do to improve the experience for your clients, the more likely they are to remain engaged in care. So once you've secured an interest and commitment from your service partners, the final step is to reinforce your agreement in writing. You may wish to establish memoranda of agreement or understanding with your community partners and include a specific referral protocol. Define roles and responsibilities for yourself and your partnering provider. Determine a step-by-step protocol for how clients will be connected to the other agency's services and identify people for clients to contact. Also identify staff with authority to address questions and concerns as they arise. Make sure you're familiar with the other agency's eligibility or intake requirements, and develop an understanding of the client experience at the other agencies so that you can prepare clients for what to expect at their first visit. Keep in regular contact with your community providers to troubleshoot problems, improve the referral process, and maintain good relationships. These partnerships will evolve over time as clients' needs and provider services change. A regular phone meeting or quarterly check-in is a good forum for reviewing any concerns. And finally, be patient. These partnerships take time and energy to establish and to function well. So next I want to review some additional strategies that you can employ as part of your Linkage to Care program. The CDC's compendium of evidence-based HIV prevention interventions and best practices includes a chapter on linkage to retention and re-engagement with HIV care. The ones I've listed here are also described in the CDC's guidance on HIV testing in non-clinical settings. So antiretroviral treatment and access to service, or ARTIS, which I'll describe in more detail in a moment. HIV navigation services is a model for helping clients along the entire continuum of care and includes services for HIV-negative people. Linkage case management, an intensive short-term assistance program which focuses on a personalized plan to help the client access services. Medical case management, an approach to ongoing coordination of medical treatment and other services, and which focuses on retaining clients in care. And finally, outreach and peer support, which is provided by people living with HIV and employs their personal experience and insights to model and assist others in engaging in care. So let's do one last poll, see if you guys are still with me, and find out which of these strategies or others you guys are currently using at your sites. Great. So it looks like a lot of case management, and not as many people, but still some doing ARTIS and navigation. Okay. Thank you, Cindy. So I'll just make an extra plug here for ARTIS. So this is a case management intervention intended for people recently diagnosed. So that's within like 6 to 12 months. And it involves up to 5 one-on-one sessions over the course of 90 days or until a client is linked to medical care. ARTIS uses a client-centered approach to focus on clients' self-identified strengths, and it seeks to develop a personalized plan and assist the client with common barriers such as transportation and emotional support. So this is something that your agency is interested in. There's more information as well as training and implementation resources available at effectiveinterventions.org. Okay, so the final piece I want to touch on today is some linkage strategies that address the concerns and needs of 2 priority populations. The first is young men of color who have sex with men, and the second is transgender women. Both of these populations experience disproportionately high rates of HIV and lower rates of testing and status awareness. And they're also less likely than other populations affected by HIV to be engaged in regular HIV-related medical care. I know when Ben did his survey, I think a lot of you serve these populations, so I just want to acknowledge that there's a lot of experience and expertise in our virtual room here, and also to keep in mind that no population-based generalization applies completely or at all to a particular individual, but being aware of the recent research findings without being bound by them can help frame your services so that they're most productive. So according to the CDC in 2014, young men who have sex with men accounted for more than 16% of new HIV diagnoses, and of these, 55% were Black, 23 were Hispanic or Latino. In fact, from 2005 to 2014, HIV diagnoses among Black and Hispanic or Latino young MSM increased about 87%. Also in 2014, the CDC estimated that the highest rates of undiagnosed infections were among youth, and that of those living with HIV, only 21% were prescribed HIV medicines and only 16% had a suppressed viral load, so the youngest rates of any age group. A 2009 HRSA initiative focused on young MSM of color and uncovered some key characteristics associated with successful linkage and retention in these diverse populations. Many young MSM of color reported that a positive relationship with their provider was paramount to their remaining engaged in care. Respondents who felt that their providers were accepting, consistent, and responsive to their life circumstances said that they were more likely to remain in care. They named respectful and non-judgmental engagement and a sense of mutual trust as important qualities in a provider, which is not surprising given that these populations are targeted by multiple layers of stigma and discrimination. The study found that systems that reduce burden on patients accessing services or make it easier for people to make and keep their appointments were also associated with greater engagement. These systems included simple paperwork or proof of eligibility, flexible scheduling or drop-in hours, appointment reminders, follow-up for missed appointments, transportation help, financial assistance in the form of gas cards or bus passes, and accompaniment to their medical visits. Retention in care was higher when healthcare services were coupled with youth-specific activities like support groups and social events, and also activities that incorporated skill building, were culturally appropriate, and focused on healthy living. Finally, the study found that young MSM of color benefit from help with juggling competing health-related priorities such as domestic violence, depression, substance use, evolving gender identity and social orientation issues, as well as general challenges of adolescent development and societal stigma and discrimination. So here's a link to the HRSA study that I just discussed. And then there's lots of other excellent resources out there to inform your work with young men of color who have sex with men. Addressing stigma that includes recommendations by NASTAD and the National Coalition for STD Directors for ensuring better health outcomes for Black and Latino gay men. The adaptation guide is produced by the CDC and is designed to assist in adapting behavior change interventions for gay and bisexual Latino and Black men. And finally, the National LGBT Health Education Center at the Fenway Institute produced a really useful compendium of best practices for serving LGBTQ subpopulations. So unfortunately, out-of-date and inaccurate research methods plague much of the data around gender and sex. But what we do know is that in 2013, the CDC estimated that the HIV prevalence among transgender women was about 22%. And the research also suggests that many transgender women living with HIV don't know their HIV status, and that there's also significant racial disparities among transgender women living with HIV, with Black or African American transgender women most likely to test HIV positive. So I'm going to give a lot of credit here to a researcher at UCSF, Jay Sevelius, who undertook interviews and focus groups with transgender women living with HIV about barriers and facilitators to engagement and retention in their HIV care. And her conclusions have been consistent with other research in the field, but she found that gender-affirming healthcare in which healthcare systems and clinical staff validate gender identity is critically important to engagement and retention. So for Linkage, this means that the providers to which you refer transgender clients should be knowledgeable about trans-related medical issues and have gender-affirming policies and procedures in place. At a minimum, providers should use a client's preferred name and pronouns and allow clients to choose bathroom and other sex-segregated facilities and systems according to their gender identity. Further, the clinic environment and non-clinical staff should explicitly welcome and respect transgender patients. Keep in mind that transgender women have a history of being wrongly identified or grouped with gay men, So therefore, some HIV providers that typically serve men who have sex with men are sometimes perceived as not being friendly or sensitive to transgender women. Some transgender women choose to take hormone replacement therapy to feminize their physical appearance. And gender-affirming hormone therapy is not contraindicated in HIV disease. So in fact, when hormone therapy and antiretroviral therapy can be integrated in an HIV primary care setting, ideally by the same provider, it ensures ideal hormone selection and dosage since there may be interactions. It helps patients to manage their appointments and medications, increases HIV treatment adherence, and helps create a positive relationship with the provider. A gender-affirming environment will also acknowledge competing health priorities for trans patients. In addition to prioritizing transition-related care, the research identified housing, social support, and mental health services as unmet needs that competed with and acted as barriers to engaging in HIV medical care. And finally, transgender staff or peers can offer unparalleled support and mentorship for transgender clients. And if these staff are also openly living with HIV, they can also model status disclosure to help reduce stigma. One small caution is that peer support and disclosure can also be seen by clients as a threat to privacy. So this approach must be balanced with the need for client confidentiality, especially in places with smaller trans communities. So in the interest of time, I'll just skip over the descriptions of these resources, but I'll quickly acknowledge also my colleagues at the Center of Excellence for Transgender Health, and they created a toolkit for the inaugural National Transgender HIV Testing Day this past April, and have a lot of other great resources on their website. So just to wrap up, there have been incredible advances in HIV testing and treatment, combining accurate, rapid diagnosis with effective care that have really helped to shift the nature of the epidemic in the United States. And the crucial remaining link, if you'll pardon the pun, is linkage to care. Thank you.
Thank you, Jesse.
Thank you.
Go ahead, Adam.